Namaste. So, good morning, everybody. It's really a great pleasure to be again in India at this very wonderful community and congress. And speak about cardiovascular health. Oh my God, it's not easy. But I really it's so big field. But I decided to share with you something new. In my opinion, is changing the paradigm of diabetes management quite soon. I will not speak about treatment because in the last years we were overwhelmed by how to treat to prevent cardiovascular disease in diabetes. I don't think that you really need this kind of help. So these are my conflict of interest. You know, this is the last ADA standard of care. And as is happening in the last years, in these guidelines, but also in all other guidelines around the world, there is a specific attention to how to manage cardiovascular disease. See that even when we are supposed to use an anti-hyperglycemic drug, we need to afford the problem of cardiovascular kidney disease. On the other side, anyhow, you also have the problem of treating hyperglycemia because as often I try to underline, in the same person with diabetes, you may have cardiovascular renal risk, but for sure you have hyperglycemia. So these two conditions very often combine in the same person with diabetes. And the same ADA is underlining that occurs hyperglycemia. Drugs for the management of hyperglycemia are important for the prevention of cardiorenal complications. But if you really want to tackle these kind of complications, you have to pay attention to also other risk factors, particularly not only to glycemic management, but also to blood pressure, lipids, and if you can, we can use specific drugs able to help prevention of cardiovascular complications. So it's clear that you need a more comprehensive approach. On the other hand, the problem of having several risk factors in the same person is a really old evidence. This study published, you see here, more than 30 years ago, well known is the Mr. Fit, was the first study showing that if you have 1, 2, 3 risk factors in the same person, the risk for CVD is amplified a lot. And if you had to this combination of risk factors, diabetes, the risk is even increasing more. So this concept is very old, meaning that in the same person, you have the combination of several risk factors. And also, we have the proof on the other side from the Steno, the study, that if you control at the target the majority of these risk factors, meaning in particular in people at high risk for having macroalbuminuria, and you control glycemia, blood pressure, and the lipids at target, you are able to significantly reduce the risk for cardiovascular complications if more than you just are unable to reach these targets. So what we learned in the last years is that it's very important to target the risk factors to reduce the risk for cardiovascular disease. There is one problem: how we are assessing the level of risk factors today. Usually, we invite our patients to come to the lab or to to a study, office, depending on the organization, in a real fasting situation, correct? In order to have a standard that is correct to standardize. The problem is that during the day, they are exposed to different conditions. The body is fasting for all the life or for 20 or for 12, 14 hours in a day. And this concept that factors can go up and down during a day, during a month, is not only related to diabetes. You see here, I'm just showing some titles of papers which were reporting that the variability of, for example, creatinine, lipids, even renal function, cholesterol variability, if visit to visit A1C variability, cholesterol. So the concept of variability of risk factors is emerging really as the new challenge for the management of complications in diabetes, which is more realistic because nobody, again, I repeat, is having stable level of risk factors during even a day. Glycemia goes up and down, blood pressure goes up and down, lipids, at least triglycerides, are changing, you will see, uric acid. So this is the new frontier of diabetes management in order to prevent cardiovascular events. I will very quickly touch each of these in order to share with you what is really emerging in this field. What about blood glucose diabetic complications? I think that this is the most new kind of variability in diabetes. We have really evidence that when glucose goes up and down, this is associated with higher risk of both micro and macroangiopathy in both either type 1 and type 2 diabetes. This has been confirmed not only by epidemiological studies, but also by several post hoc analysis of very well-established trials. So the power of the evidence is very strong. You have in the advanced DEVOTE, VADT, EMPA-REG, ALL-HET, and ACCORD, all these studies, when we had performed sub-study, confirm that glucose variability is independently associated to the risk of microvascular complications. But what we have recently reported is something very important for clinical practice. In cooperation with the diabetes registry, Swedish diabetes registry, you know this is unique registry in the world. It's following all the population of Sweden. So all the people living in Sweden, they have a record of what happens there to them in terms of health. And then in cooperation with them, we were able to, first of all, confirm that glucose variability is related to almost any kind of cardiovascular. But, and this is very clinically relevant, we were showing that particularly in people at target for A1C, if they have a huge variability, they are at increased risk for complication compared to people having high A1C and low variability. In other words, to have people at a target of A1C is not enough if glucose variability is high and so exposing people to high risk for complications. Probably the key is the increased hypoglycemia. We never will have the proof, but some studies are suggesting this. What about blood pressure? Oh, this is also a very important database coming from Brazil, And again, they were able to show that blood pressure variability in time is correlated to high risk of cardiovascular mortality and also cardiovascular mortality and total mortality. But what about the accord? You know, the accord had two branches, let's say. One was glucose control, the other one was blood pressure control. And also you see that looking at the study performed in terms of blood pressure control, in either accord and VADT, it has been reported that the blood pressure variability is related to higher risk of cardiovascular events. Of course, I'm reporting only few studies. The evidence is more widely. If you are interested, there are some very important review on this topic. But what about blood lipids? Oh, you see here, in this study, having 10-year follow-up, the greater variability in lipids associated with the cardiovascular mortality, and you see here the data. So again, when we speak about the glucose variability, in this case, because we are looking at long-term variability, we do not speak only about the triglyceride, but also in terms of variability related to LDL cholesterol and HDL cholesterol. So at the end of the day, we have evidence that also when lipids in years, they are not constant and going up and down, this increases the risk for cardiovascular complications. Again, more specific, LDL variability is linked to increases the risk of cardiovascular events in patients with type 2 diabetes. But surprisingly, we have also evidence supporting a role for uric acid. You know, uric acid has emerged a risk factor for cardiovascular disease. And we have evidence that uric acid variability is a marker or is associated as to an increased risk for cardiovascular disease in type 2. You see here again the curves of this study. But more recently, the problem of weight is so cool. Now we have a very good strategies, drugs, and we are now aware that body weight is a really important risk factor for cardiovascular events. What happens in the real life? I think this is a very common experience. People are going down in the weight. This is not difficult. What I mean, it's difficult, but the motivation is very high. Many are successful in lowering the weight, just with diet, or recently with these new drugs. But what happens when they stop the diet or they stop the treatment? They regain weight. And this is defined the so-called yo-yo effect. Well, how it impacts the weight on cardiovascular disease? It is interesting. Maybe you remember the look ahead study. This study was planned to show that weight reduction can reduce in type 2 diabetes the risk for cardiovascular disease. Surprisingly, this did not happen. So people were lowering the weight, but no effect in lowering the risk for cardiovascular disease. But if you see at the long-term follow-up or the look ahead, we got a very interesting information. Cardiovascular disease can be linked to a decrease of body weight, but only if people are able to keep the new weight. Because also in the look ahead, just lowering weight was not enough. And many were regaining weight in time. A group of these people were so strong to keep in years the weight. In these people, in some, we saw this new concept of diabetes remission. But importantly for what we are sharing, we saw that the cardiovascular disease risk was very low, meaning that lowering weight by itself seems to be not enough if you are unable to keep this in the long term. And again, in cooperation with the Swedish Diabetes Registry, we were able to show in diabetes something that was already demonstrated in non-diabetes, meaning that the yo-yo effect is related to a very high risk for cardiovascular complications in diabetes. And this meta-analysis, published almost at the same time our paper, confirmed this finding. Body weight variability has been related to higher risk of cardiovascular disease. And recently, if you want, I was shortening my presentation, we demonstrated this pulling the data of several trials, also in type 1. So this body weight variability seems to be really very. But I started to say that in the same person, you have multiple risk factors. Of course, you may have the variability of these multiple risk factors. You do not have that only glycemia goes up and down, or weight is going up and down, or blood pressure. You can have a combination of these. So it's clear that if, as demonstrated by Mr. Fate, the combination of different risk factors increase dramatically the risk for cardiovascular disease, we have to wonder what happens when we combine the variability of several risk factors. And we were performing this very sophisticated statistical analysis, again with the Swedish guys, where we perform the ranking, meaning pooling the variability of all the risk factors in this database of people not at risk at entry, without complications, at the entry in the study. Who is emerging as the most important? You see here, the most important is body weight variability. What means this? Means that if in the same person you have the variability of different risk factors, body weight variability emerges as the most powerful risk factor. Meaning that in clinical practice, one of the main goals is to lower the weight, but particularly to keep stable the weight. Because otherwise, this can influence the other risk factors variability. And then the combination, you see the sequence, then if you have a body weight variability added to blood pressure variabilities, is increased even more. But the concept are two. First, body weight variability is the most powerful risk factor in terms of variability. Second, if you combine different variabilities of risk factor, the effect is dramatically amplified and nobody can be surprised, no, I think. So we can conclude that body weight, that the risk factors variability is really emerging problem in the management activities. Probably this means that we have to revise our approach, but also how we measure the risk factors. We have to be more close to the real life. In the real life, nobody is in fasting situation for more than, let's say, 8 hours during the night. The reality is that human beings today spend the majority of their life in post-meal situation. And during the day, several changes of risk factors happen. All are changing over the day or over the months. And this is the new frontier for a correct management of cardiovascular risk in diabetes. But I want to show with you something really intriguing, because now everybody is thinking, which drugs are the best? What can we use? No? Body weight, maybe GLP-1, so cool today. Blood pressure, which combination? Lipids, statin plus, and to put all together, well, using, in this case, an Italian database, we were able to show that if you want to really control the variability of risk factors, you must have a very good quality of care. So it's meaning that, okay, if you have the good drugs, but you do not use in the right way, does not work. And this concept seems very, let's say, naive. Better treatment, better care is able to reduce the risk for complications. But we demonstrated that a better care means also to better control the variability of risk factors, so a better care can help to afford this new horizon of diabetes management. So, in conclusion, in most of the intervention studies in the setting of type 2 diabetes, a reduction in the magnitude of diverse severe risk factors have translated into really good benefit on hard endpoints. On the other side, no trial has clear proven that a reduction in variability per se, independently of the risk factor magnitude, is beneficial. This is correct. However, evidence is growing, suggesting that the variability of a risk factor might be no less dangerous than its magnitude and or the time spent having it in abnormal level. Moreover, it's also enough clear that the variability of each factor is additive in leading to the final picture of a diabetic complications. Therefore, from a therapeutic viewpoint, it's time to try to reduce both magnitude and variability of risk factor. I put a question mark because, of course, we do not have a trial yet, but it's clear that this will be the new frontier of diabetes management. Because an improvement of the quality of care and the attainment of their target seems to be the best strategy to reach this goal, honestly, I believe that the answer is not so complicated. Thank you. Thank you very much for your attention.